Welcome back to the Dental Implant Podcast, and I am excited to talk to my very good friend, Dr. Uzman Haq again. If you remember, Dr. Uzman and myself, we discussed short implants not very long ago. And Uzman and I, we recently were privileged to be taken over to Meisinger in Germany, where they've asked us to join the training team on their global bone management network. And one of the reasons why I wanted to get us on here is because we're actually running a course on autogenous grafting. One of the main reasons why I wanted him on here at the moment is just to go over our journey with like biomaterials and kind of like as our careers have progressed, kind of like the why we've almost come full circle back to autogenous. So it was just briefly just introduce yourself again, and then we'll just have a chat basically. So introduce yourself to Titanium Nerd Central.
So hello everybody, I'm Dr. Uzman Haq. I am a good friend of Fav's, basically I'm a peripatetic implant surgeon going around the country placing implants, doing minor oral surgery and stuff. It's weird because once you kind of get this, it's like an epiphany, right? When it comes to autogenous, it's kind of like, once suddenly it starts clicking, you're kind of like, wait a second, why didn't I do this before? And I've been thinking quite a lot actually about a lot of this stuff. Why have I been using so many biomaterials there before? Why have I not gone down this autogenous route there before? And for me, I know the route for you might be different, but for me, I would say I think the route for pretty much everybody is fear more than anything else. And then everything else after that becomes a justification for that fear, right? So the idea that the ease of getting stuff out of a packet, you're told horror stories like you're going to make the patient numb, you're going to get them severe, the second sight morbidity, there's different varying kind of levels of fear. And before you start doing implants, you're always kind of worried about, oh, you know what? I don't want to touch somebody else's implants. I'm going to own that case. I'm going to end up, if something goes wrong, it's going to cost me thousands because, I'm having to deal with the patient. And the same thing with autogenous is basically you've had that fear in your head that, you know what, I'm going to cause this patient a problem. I'm going to make this situation worse. And then you at the same time get bombarded by continuous messages saying, actually, you know what, we can justify that fear of yours and actually give you something that kind of means that you don't have to face that fear and, and go and harvest autogenous and stuff like that. So for me, it was kind of more like when I got really into the fact of, do you know what, I want to do a practice limited to implants there only. Then after that, it was like, you know what, how can you do a practice that is limited to implants only and you're not doing oral surgery around the mouth? You're happy opening a sinus, but you're not happy lifting up a ramus flap to remove bone, or you've done multiple symphyseal flaps to remove cysts when you're an SHO, but now suddenly it's like, don't want to touch that. Patient might get a bit numb, even though the quality of the bone inside the mouth and stuff. So yeah, it's I guess we'll go through a bit more with this a bit later, but I'm not averse to biomaterials. I'm not one of these people who just like, get away from it. I would never touch it. I just kind of feel that the problem with biomaterials is every biomaterial company is acting like their biomaterial is a panacea, basically, right? So it's like our biomaterial can solve every single problem that you can think of. Our synthetics do absolutely everything that autogenous and xeno can do. Our xenos there can do absolutely everything that autogenous can do, and that because of that, you end up in a situation where you just kind of think, you know what, I'll just stick to, you know, what the companies are saying. And unfortunately, we're getting to the stage there now where obviously we're placing implants, and these implants are staying, you know, in the patient's mouth there for, you know, 20 plus years, and we've got to be looking at what could cause a problem 20 odd years down the line. And you can see that some of these biomaterial, you know, grafts and things are causing problems, you know, later on down the line. So, yeah, with me, I wouldn't say it's 100% turnaround, but I'd say that's 90%, basically.
Yeah, so I think I'm in a similar boat to yourself. And again, what I'd qualify is, you know, we're not sat here saying, you know, biomaterials have no place, and we're not singling out like any biomaterial company. That's not what we're here discussing at all. I think probably the best way for me to describe it is when I was less experienced with surgery and with implants, there was a certain level of comfort taking it out of the packet because surgery is stressful enough anyway. And to think to yourself, well, effectively, I'm doing surgery twice in two different areas of the mouth. You're absolutely right. It comes down to that fear. And what I generally find is when you're fearful of something or when you're nervous about something, it's purely down to lack of knowledge and lack of experience. You know, is that the number of people that I speak to who are fearful about, fearful about exposing a mental nerve. When I show them how to do it and they go, "Is that it?" I was like, "Yeah." Then all of a sudden that fear disappears, and harvesting autogenous is no different. And I think what's happened as well over the years is obviously you go on courses sponsored by these companies. You get shown some good cases, and sometimes the material works very nicely. I think there is an aspect of how you use it and in what situation you use it. I don't think that any material except autogenous is a true panacea. Okay, autogenous you can use absolutely anywhere. You really can, as long as you're adhering to the correct biological principles. All biomaterials have a limitation to some extent. Okay, and what I found over the years is, I've tried this material and I've had mixed results or good results in certain instances and not great results in other instances. And the more experience that I've developed over the years, it's just like, I need something more and more predictable every single time. And when you start to speak to the top grafters on the planet, if you're talking about Prof. Urban, yes, he uses biomaterials, but he mixes a lot with autogenous. In fact, in terms of percentages, even when he mixes with autogenous, even when he mixes with a xenograft, the bulk of the graft is still made up with autogenous. And Balaji in the UK, another friend of ours, he uses Prof. Urban's techniques as well, and he uses a lot of autogenous. When you want to start doing bigger grafting cases, when you want to start doing more predictable grafting, I think it's very difficult to get away from. And one of the as you said, you had this epiphany. One epiphany that I had is probably about 7 years ago now. I had a patient where he was like, Pav, I had this implant placed 20 years ago. And unfortunately, the implant neck had fractured. And the implant was done by a very highly respected surgeon. I've got a huge amount of respect for this surgeon. And it was done absolutely beautifully. And it was BioOS that we used. And there was the implant placement was perfect, as I'd expect. The restoration was absolutely, it was just fatigue that caused the neck a bit to fracture. So we had to go in and we had to remove this implant and then go back in and do it again. And bearing in mind that, and he knew that he'd had BioOS placed because he was so organized. He still had the little leaflet, which he came in to show me. And so 20 years later, I went in and I took the implant out. What did I find in there? BioOS granules, which meant after 20 years, it hadn't turned over into bone. Now, it's not necessarily a bad thing because you can argue, look, it's been in place 20 years. But for me, just my personal way of doing it, my personal philosophy, and this again comes down to the training that I've had. But people look at autogenous incorrectly, in that a lot of these companies where they come out and they say, oh yeah, you know what, is after 6 months you have 50% bone or 60% bone, whatever it is. And you ask them, what markers are you actually using to make that assessment? And it's normally just vascularity, which actually doesn't have a huge amount more to do with actual conversion of the biomaterial into bone. Because what I'm looking for is, I'm looking for the same number of cells, the same health of the cells, and the same cell profile as well. So I want the same number of osteoblasts, osteoclasts, and osteocytes. Because those osteocytes, they're really important, because they're the they're the conductors of the orchestra, which turn around and they orchestrate between the osteoblasts and osteoclasts for true homeostasis of the bone. So if you haven't got the correct cell profile in there, it's not, it's a potential compromise. And by the simple switch of just using autogenous bone, and the caveat that I would put on that is using autogenous bone in the correct fashion, then you know that actually, you know what, it's live bone, it's vascularized, it's got the same cell profile, it's just bone. You've rebuilt true bone. So that's kind of like the journey that I've been on over the years. And as I said, I've used synthetics. I still use some synthetics sometimes. I still use other biomaterials sometimes. Because, occasionally I'll get a patient where they'll turn around and say, I don't want you taking bone from elsewhere in my mouth. I respect that. Some people turn around and say, I don't want bone taken from elsewhere in my mouth. I don't want you to use animal products. Fine, that's not a problem. But again, it's, the vast majority of cases now, they're leaning more and more towards autogenous. And I've got to say, I'm really happy with the results that I'm getting.
Yeah. I mean, that's the thing. I'm almost getting to the stage there where somebody is like really insistent, I want to use a certain biomaterial. I'm almost refusing the case, because, at the end of the day, it's the same thing with discounts and stuff like that. You can give a discount to a patient. You can basically use whatever biomaterial that, you want. Who ultimately takes responsibility for that? It's the surgeon who's taking responsibility for it, right? So just because you're using the biomaterial that the patient requests, they're not kind of thinking to themselves, oh, you know what, well, he's told me that this is going to work, not as well as if he does it the other way, so I'm going to accept that. They're not going to accept that. If your implant fails, the implant fails. And it's interesting you were saying about the turnover case. I showed you a case there a while back where basically a patient during the pandemic had gone to another practice and basically had a ridge preservation graft, which I suspect now is with BioOS, having actually removed all of the graft there from it. Patient was told it was synthetic. And, like I said, I'm not against biomaterials. It's just they have to be used in the correct way. And basically, if you're putting pure BioOS into a socket, what that is doing is that is freezing that socket in time, right? And what you need to do is you need to go back into that socket and get rid of the whole thing. So you've got a kind of a run gap of space around your implant, so that your osteogenic activity can occur around the implant there, and you can actually get true integration. What you can't do is drill straight through that BioOS and then basically then go and expect those BioOS particles to somehow integrate into your implant. And like I was saying, I had that case that I showed you where patient during the pandemic had a ridge preservation graft. They obviously thought they were doing the right thing there. Patient told me it was synthetic, and I just took her word for it. CT scan, 7 mil wide bone, put in a 4 mil implant in there. 2 weeks later, there's just pus draining from the buccal, right? Uneventful surgery, straightforward, 50 Newton centimeters of torque there, very, straightforward placement. Went back in there, took the implant out, and literally just with a Lucas curette, just scooped out all this biomaterial. I mean, that's been in there since 2020. 3 years. And as soon as I drilled into it, the whole thing just collapsed, right? And this is one of the things that we're going to be going through in the course there as well, which is like, what you're saying is the more education you get, the more your kind of mind changes about stuff. I was always told when I was training about how superior block graphs were and things like that. And now, obviously from knowing, you can see that actually, well, when you're block grafting, it's in effect a dead graft. It's just a dead block of bone that you're putting your implant into. I used to, when I was training, I used to hear stories about how my mentees would basically go and do a block graft for for a student on the course, right? And then they'll be saying, oh yeah, and that idiot took it to the practice, and then he put an implant in, the block fell off, and they had to put GBR on it. And you'd all be laughing like, oh yeah, what an idiot, it's just not. But actually, it's because that block never integrated in the first place. If that block falls off, it is dead bone that is not integrated, right? It should not be falling off the site there. So the main thing with any biomaterial you use is why you're using it. Now, we know that, from what you've told and what I've just said there now, that biowas has the ability to stay there for a long, long time. So what Rob Beretti does is he does this technique where if you've got a very thin, say, buckle bone profile, right? And you're placing an immediate in there or something, he does an inside-outside graft where he'll put like an auto mix in the run gap next to your implant. And on the outside of the buccal plate, he'll put Xeno on there, right? Because he knows that Xeno is not going to resorb and it protects the buccal plate that is on the inside. You've got to be using stuff and know kind of how it's working and how to use it. And this is the way that I feel like, shameless plug for the course there now, right? But basically, like, this is the way that I feel about courses, because one of the things when I go on courses there is there's an expected level of the people who go on courses, right? And it's kind of like, it's a given. You're kind of expected to be able to do this or whatever. And I can go and I'm going to be teaching on the course, how to use safe scrapers, how to harvest bone, things like that there as well. I don't actually use safe scrapers anymore. I use Automax spurs. And the reason being is I'm more than happy lifting up a Ramus flap, going in there at 600 RPM with the Automax spur. I know exactly where it's going. I know I'm not going to hit the nerve, and I'll just go in there and do it. Do I expect somebody who's done this 1 or 2 times to do that? No. You should be going in there, lifting your Ramus flap, slowly going in with your safe scraper, and you do that 10, 15, 20 times. You get the feel of it. And then when you've done that and you say, do you know what? I want to be a bit faster, or I'm confident in that. I want to get a tree fine out, or I want to get an Automax, bone chip collector or something like that. Then fine. Then you move on to that level. Too many times I see courses where they're like, just do this, and it's like, okay, fine, people are going to get into trouble from this because they're going to go straight in, be told a particular instrumentation and something to use, and it's not safe for them to do it at that stage. But once they get the experience, then it's like, right, okay, in our course, basically what we're trying to do is make it that it's like, okay, fine, we're teaching you the safe scraper technique. So I want you now to go back, do a safe scraper technique, show me in PAV 5-10 times where you've lifted a Ramus flap and done this technique, show us some photos, and then we can say, do you know what? You're able to do this now. Maybe you can move on to the next stage, right? Instead of being like, oh, let's go straight on and do a massive, massive graft or a curry plate or something like that. You know what I mean? It's like, it's it's difficult. And this is one of the things that you're going to be teaching there as well, as the bone core technique, right? And one of the things that I like about that is it gets people used to using screws, right? Because if you're not used to using screws, then how are you going to suddenly go and harvest a curry plate, drill holes, do all that kind of stuff? When you're doing something like a bone core technique, it's like, okay, I'm getting used to drilling holes into bone, screwing in there, It's not too much of a involved process, because I'm not harvesting bone from the ramus and doing a much more risky procedure. It's literally all within the window of where the bone is. But you get used to using screws, so you do multiple amounts of screws, and it's like, okay, I know now how to drill a hole, how to put screws in. It's like, I can go on about this forever, mate. But this is the thing: is like, now, like, I don't even use like, I just started using the Ixos self tap screws, right? And they're much more expensive, but they're kind of like this ultra sharp tip screw, right? And basically, I use it there for, if I'm putting a membrane, even if it's, say, if I'm putting a PTFE membrane or something in, I don't know about your patients. My patients don't like me getting out mallets and stuff, unless they're sedated, right? But I can get one of these ultra sharp, self tap screws and just screw those in there. And I'm less and less drilling holes there now. I'm kind of just using the self taps more and more. And it's just one of those things. Just because you're comfortable with doing it, then you can go to that. But I wouldn't expect someone to be like, "Oh, I want to just use self taps." And it's like, you need to learn how to be able to drill a hole through a split bone plate into into the rest of the cortical bone without causing any damage, and then use that pathway to put your screw in. Once you've done that, then yeah, okay, fine, then you can move on to self taps and stuff. But there needs to be that progression.
Yeah, so I mean, there's a few things that I wanted to mention off the back of that as well. So, firstly, with regards to Rob, I agree. He's a lovely guy, and he's absolutely world class. His stuff is, I know that he runs courses as well, and I agree with him. So, the points where I agree with him is that that's the indications that I use a Xeno or something that's non-resorbing when we're going outside of the envelope. I believe that's the true indication for it. It's the same argument that Rob uses. Rob, if you're listening, hi mate, how you doing? And the other thing that you mentioned there as well is the difference between block grafting and split bone blocks. So our mentor, Sharif Kutchuk, he spent 4 years at Prof Kuri's practice, and Prof Kuri is basically the inventor of the split bone block technique or the Kuri plate technique, and it goes back to Albrechtson's data in 1982. It might have been a little bit earlier than that. What Albrechtson found is when you've got a bone block, the angiogenesis penetration into that block is 0.05 millimeters per day. And if you've got particulate, it's 0.5 millimeters per day. So you get the angiogenesis into granular material 10 times faster than what you do block. That's why blocks are no good, because by the time you've got angiogenesis through, it's already died. That's why you put these blocks in, you drill in 6 months later, and they just fall off. So what happens with and out of respect, I'm going to call it Kuri's technique, Kuri plate technique, because I think he deserves that recognition, is because you've got a thin cortical plate on either side, and you've got this granular autogenous material in the middle. So there's a few things that's happening there. So a lot of biomaterials, they are purely osteoconductive, okay? Whereas autogenous is osteoconductive, osteoinductive, and osteogenic. It's all three, okay? When people say, this is the holy grail of biomaterials, it's like, well, we've got one. It's autogenous. It's like, why are we gunning for something when we already have it there? And so when you have that, and you have the cortical plates on either side, and you've got this granular material, you haven't got angiogenesis or healing happening from one side to the other. Each one of those bone shavings, those bone chips, those autogenous bone chips, that's an osteogenic center. So the healing happens in 360 degrees from the inside outwards in every single direction. This is one of the reasons why it's such a powerful technique. And then going back to the other point that you made as well is listen, mate, you and I know when it comes to implants, everything is a progression, right? When you first start placing implants, you're not going to be doing pterygoids, nasalis, zygomatics. You build up to that. And it's the same, you don't start off and, your second case is a large lateral sinus lift technique. And the same is true with grafting and autogenous grafting as well. Okay, so a lot of people start turning around and saying, "Well, you know what? You're going to have a second donor site. There's going to be a lot of morbidity. Patients won't go for it." I'll tell you what: the patients will go for whatever you tell them is the best. Whatever you tell them is going to give them the best result. So if you talk them out of autogenous bone, they're not going to have autogenous bone done. If you talk them about the benefits of autogenous bone, they don't have a problem doing it. And we don't always have to go remote. Sometimes we can work very, very close to the site where we're already working. But the whole point is we start off simple. We start off simple autogenous harvesting and ridge preservation. Okay. Then we start off simple grafting and ridge splitting, osteoperiosteal flaps, things like that. Okay. And then once we start to get used to it, that's when we can start to look at, let's do a larger horizontal graft. Let's now do a parallel technique, vertical graft. Let's look at tunnel grafts. Let's look at right angle techniques and sandwich sinus techniques and all sorts of things like that. Again, a big mistake people make is, I was working with somebody, this was a while ago, and they watched me use the piezo to harvest bone from the palate to use for a Curie plate technique. And they were like, I think I'm going to do that. and I was like, hang on, let's slowly build up your skill over time, because actually harvesting from the palate is not the easiest of things to do. And I think, you and I have been down this route. We're still, I always say that, I'm still learning. I'm still a learner. I'm forever learning. And the game's really simple. Stay curious and keep learning. As soon as we think to ourselves, we know enough, then we do ourselves a disservice. We do our patients a disservice. So I'm always curious, and it may be that 10 years down the line that we're sat here saying, oh, look at this fantastic new biomaterial. Do you remember that time when we used to use autogenous all the time?
Yeah, it'd be AI material that's come out or something.
At the moment, it's kind of like, we've been through the process of using all these different biomaterials, just getting stuck with them, having okay results. Don't get me wrong. Sometimes you have great results. Sometimes you have okay results. And other times you have results where it's just like, you know what, I just need to take it out and start again. And for me, it's the predictability that I need in doing that. And that's kind of like what's brought me full circle to here. So for those listening, you need to understand, as with everything, and this is true for everything in life, is if you pass your driving test, you're not going to go on a Formula One circuit, or you're not going to go to Silverstone, like 2 days after you've passed. You're going to build up experience. You're going to build up knowledge. And then over time, if you find that that's what you want to do, that's what you do. So, and this is kind of like the point that we are trying to get across as well, in that, let's show you the simple techniques first, because I think that the ridge splitting is grossly underused. And I've got a lot of cases at the moment where I'm just looking at it and I'm like, I think what ends up happening is we end up hell-bent on preserving the volume of the ridge. And now I've got some cases where I'm like, screw it, take the tooth out, disinfect it, let it collapse, and then I'll rebuild it in autogenous, knowing that I'll probably just have to do a ridge split and that's it, we're done. And again, ridge splitting it's a very underutilized technique. And the osteoperiosteal flap, particularly the eye flap, is poorly understood, because the gentleman who invented it, Ole Jensen, again, he's one of the best grafters on the planet. He's just not as well known as what some of the other people are. But basically, the osteoperiosteal flap is a way of doing a ridge split, but maximizing the blood supply as well. So you're more likely to have success. And you can do some crazy stuff for that. You can do some crazy stuff for that. So I think we need to move away a little bit in my opinion,
Mm.
from being completely hell-bent on we've got to preserve this at all cost, because sometimes that cost is now you haven't got bone. Now what are you going to do?
Yeah.
And
Yeah.
move more towards learning the skills to rebuild. And again, I respect the fact that, there's going to be a lot of people out there who disagree with us. There's going to be a lot of people out there who are like, I've used allograft for 20 years that I have a problem. And we don't have a problem with you using that either. It's just my philosophy is, in my mind, I'm just a lot more comfortable. And it's just like, I've got real 100% bone that is fully viable, that I know is exactly the same as the patient's native bone, sat all the way around the implant, And when you speak to some of the bigger grafters, they'll turn around and say, oh, if you do a really complex ridge preservation, you've got to engage native bone beyond where you've actually grafted. It's like, well, why? Is if you've grafted and it's real bone, you shouldn't have to do that. So
Yeah. And this
that's
is,
then another reason why I've just moved back towards autogenous.
and that's the reason why I ridge preserve with auto, because basically, like, the thing is, going back to that fear aspect from before. Okay, it was just more convenient. Open up packet, put the stuff in, whatever. Now it's kind of like, okay, well, I've already numbed this patient up in the site there where I'm taking the tooth out. I've also numbed up the ramus at the same time. And I usually do unilateral. So I basically, like, if I'm doing, say, an upper four, I'll be numbing up the right side ramus, right? And I'll basically numb up both sides. I've got the tooth out, 5 minutes, tooth is out, flap is up, 30-40 seconds, Automax burr on. I've harvested 0.5 cc of autogenous bone within less than 12 seconds of doing that, and if I want more, then that's fine.
Quicker
And
than
then
opening a packet.
without even opening a packet, and basically what I then do is just harvest that out of the burr, pack it straight in the site there. The only thing that I generally use, which I guess is biomaterial, is sealants, because sometimes I find that unless you got a big defect and you're doing like a connective tissue rotation flap or something like that, I can get quite good results there by just having autogenous scrapings or using an automat burr, which I'll explain to you guys what an automat burr is in a minute, and then basically just taking that, packing that in the site, collagen sponge over the top, figure of 8 suture. I'm done in 30 minutes. The thing is, I go back in there in 3 months. I'll take a CT scan in 3 months, and it's almost the same ridge. And I know, okay, say the tooth was 12 millimeters long, right? Okay, fine. If I put in a 10 mil long implant, I know that is 100% in autogenous bone from top to bottom, right? It's not like, okay, we had a 12 mil root, I've put a whole load of biomaterial in there, I need to put in a 14 to 15 mil implant minimum so that I can engage in some autogenous bone there after that. I'm completely in autogenous, so it's, and the thing is, when you see the way that these cases look, sometimes you do a graft there with biomaterial like xenograft or something, and you go back in and you open it up, and it's got that biossy look, like it's like gravelly on the top kind of thing, right? And when you start drilling into it, it's like, oh, it's churning it up. And this is the thing, when I was training, I was told, like, if you're going back into a sinus and you've put, like, biowas or whatever, because we were using 100% biowas in the sinus, and I was told, okay, when you go back into that sinus, then you better make sure that you're running the drill at 500 RPM rather than 1,000 RPM. And I was like, why? It's like, well, you churn the graft up. Okay, now I'm looking at it thinking, that graph's not that stable if it's getting churned up at at certain RPMs. Back in the day, it's kind of like, okay, fine, that's just a given. And sometimes you find that at that point, then when you're doing, say, for example, a sinus graft, and you've just got xeno in there or allograft or whatever, and you say got 3 mils of height of the patient's bone and 7 mils of of xeno or allo, then what is your implant actually in? Say you put a 10 mil implant in there, it's only 30% of it is in actual bone. The rest of it is just in random osteoid, that is around there. So there are certain tools that you can
I call it
use.
zombie bone because I don't really
Zombie
know what it
bone.
is.
Oh, that's
It's
yeah,
some sort of weird zombie hybrid bone.
yeah, and it's kind of like you know, the thing is there now is that there there was always this kind of idea that, okay, you know what, it's just literally easier. Just I've taken the tooth out. There's like a big effort to take the tooth out, for example, and then you're like, okay, do you know what? I really can't be bothered to lift this flap and do this and stuff like that. But this kind of goes back to the mindset, and this is another thing that I talk about in the course there. Basically, I believe the mindset for the average person on I'm going to say something very strange in a minute, but basically, my mindset when it comes to extractions, I believe for dentists is wrong, and I believe we need to make extractions great again, right? Because basically, extract an extraction, somebody should think about an extraction the same way they think about a molar endo. Okay, this should be an event for the patient. You should be like, right, I'm booking you in for an hour. I mean, you know, most people when they're taking a tooth out, they're like, right, 20 minutes, let's get him in, let's get this tooth out, let's get him out, right? That's basically the way most people think about it. But with me, my minimum is an hour. I go in there, I numb the tooth up, I talk to the patient. I'm basically like, I section the tooth, I remove it atraumatically, I harvest the bone, I pack it in there, I put my collagen sponges, I suture it, I check it, I make sure it's all, everything's all completely secure. And that may take me 30-40 minutes. And, we've got 10 minutes set up and 10-minute close down. Now, when I say to people, I take an hour to take a tooth out, it didn't take me an hour to take the tooth out, but it's the mindset of thinking, I'm gonna charge that patient a certain amount of money, which is to the way that I charge equivalent to a molar endo. People probably think that's mad, but my extraction, I ridge preserve everything, like literally everything, right? Even if the patient's like, I don't want an implant, fine, I'll ridge preserve it. You might need it and want it in 5 years, right? Every single time is like, this is what it costs. It's the same as a molar endo. I book him in for an hour and I do the same procedure every single time. And the reason for that is basically, once you start getting in that mindset of, you know what, extraction is not just an extraction. Your extraction is a means to an end. So kind of like the way that you're thinking, that you're looking at it and you're saying, do you know what? Okay, fine. This is going to collapse, right? Sometimes you look at it and you think this is going to collapse. So you're just like, do you know what? I'll let it collapse. I'll come back later. I'll expand it. Or like when I look at it and I say, all these walls are intact. What are we doing? Let's ridge preserve this. Let's get some cortical scrapings in there or whatever. And then I know that is going to be a decent ridge there later on. Thinking in that mindset, you then get the idea that actually it's not a rush to get this tooth out. It's not a rush to get the patient out the door there and get them out of pain, all this kind of stuff. It is literally like, I'm going in there, the extraction is the first part, then I'm going to preserve this ridge, then I'm going to suture it down, then I'm going to talk the patient through, and it's basically the first step on the journey that they're carrying on with. And once people think of it in that way, it's a very different kind of idea, right? It's not just like, then when you think of it in that way, then when you think, oh, you know what, I'm just getting something out of a packet, then you kind of think, okay, is I'm making enough effort there? That's not, then at that point it's like, I'm not making enough effort to justify the fee that I'm charging there for the patient and what I could actually do there for them, which is preserving that ridge as much as possible. And that's why we designed the course the way that we did. So there is a clear progression. So kind of like the first thing is, what why autogenous is beneficial, and then basically going on to how we ridge preserve in a very kind of simple manner by using Ramus flaps and safe scrapers, and then progressing into right now you can do that. Now we're doing Symphysil flaps, and we're doing harvesting with automat spurs, and doing bone core technique, and doing slow drilling protocols there as well. And with all of that, you've got there's a thing, this from mentoring, right? There's a thing amongst people that they want to jump to that highest level as quick as possible, right? And the way that I kind of liken it is, I had a schoolmate who became a vet, right? And he's got a friend who basically is his partner in the veterinary practice, right? His partner's never in that practice because he's always down at Woburn Safari Park doing these works on lions and elephants and all this kind of stuff, right? And the other guy, who is my friend, is like, you know what? Yeah, he gets bored of doing cat and dog every single day. And I love doing cat and dog every single day. Yeah. And that's kind of the way that I see me and you, right? Like you love that stuff where it's just like, dude, I love doing these zygomas in these big cases and stuff like that. And it's like, yeah, that's great. And I also love preserving this ridge and making sure that I make a nice, easy treatment there for the patient. And looking at you, we get the same satisfaction when we're doing different levels of treatment. And it doesn't mean that, you could go and be like, you know what, I'm satisfied with knowing how to do a bone core technique, how to harvest bone there, and how to do a slow drilling protocol and do straightforward, simple grafting. That's fine. You don't need to go any further than that if you don't want to, right? If you want to, however, we can also teach you the other stuff on top of that as well.
And yeah, I absolutely agree with you. It's, a lot of people, myself included, want to jump the gun. And this was true when I was younger as well. It's like, even when I was the very first course that I did, the gentleman who was teaching me, Rich Brookshaw, and Riz taught me as well. They were doing a lot of all on fours. I hadn't placed my first implant yet, and I was just like, I want to do an all on four. And you have it in your mind that it's sexy to be doing all on four. It's you think, oh yeah, if I can do that, then I'm an implant surgeon. And you start doing it, and then you see people doing crazy shit. Then you see people like Rich and Riz, they're doing zygomas. Okay, cool. I want to start doing that. Then you learn that there's pterygoids, there's nasalis, there's transnasal. This is why I'm saying, the learning never stops. But we almost need to take it back a step. That instead of wanting to do something for the sake of wanting to do it because you want to be on the upper echelons of this, is we need to be like, okay, what best serves our patients? And if I want to get to that, to that level, whatever it is, whatever you are. And there are some people who are like, they don't want to do that, but they're really hyper focused on really high end cosmetic work, and they get absolutely brilliant results. It's just taking things one step at a time. And again, this goes back to what I was saying, what you were mentioning as well, is don't jump the gun. If you start to learn autogenous, don't let your second or third case be, a quadrant vertical reconstruction, because you're asking for trouble. Start off simply. Start off with ridge preservation, start off with a simple ridge split, with a simple horizontal graft, and then start to build up from there. So one of the things that I've had reasonable, pretty good success with actually is I've had a few patients where, and let me be clear on this, the evidence suggests that this doesn't preserve ridge volume, but just putting PRF slugs into a site and suturing. When I go back 3 months later, the quality of the bone that I have is superb. And the reason for that is the PRF, you're creating an environment which wants to heal. That's purely what it comes down to. So when I do that, my aim isn't to preserve ridge volume. My aim is to give a site where the body wants to heal because it's got because it's got everything that it needs. Now, you make sticky bone out of autogenous.
Mm.
Now we're cooking. Now we're on now we're on another level entirely.
Yeah.
I think it's a missed trick.
Yeah, I mean, this is one of my favorite things to do, basically, because also as well, like I'm saying, it's that change in mindset, right? So you're, like I said, you're spending an hour doing your extraction, whatever. Patients love it, man. They're looking at this centrifuge spinning around. They got their bloods there. You take it out. You do this thing. They're like, "Whoa, what? You took this out of me? You're mixing this thing together." You get this thing that looks like, basically like a pineapple ice cream that you kind of made there together, and is basically like that is gonna they can't. The concept of doing all that there together is the science behind it is that basically you've got all of that potential there of the autogenous bone, the osteogenic potential there, the osteoconductive and osteoinductive there as well. But also at the same time, one of the big things that people are always complain about autogenous is it disappears very quickly, right? And there are certain techniques that you can use to keep that autogenous bone within your site when you're ridge preserving, or keep that in a particular area there to stop it slopping and things like that, because it sticks to each other. But the fact that it has all of those properties there is that the body just sees it as this great nutritional source and just resorbs the whole thing away. When you mix it with and sticky bone there is slightly different, because you're actually taking the PRS slug, but also at the same time you're taking PRP, so you're taking out 2 bottles there after a few minutes, and you're mixing that there together, and you basically form like a ball. It's like calcinol, basically, like when you form it there together. You could roll it in a ball, and then you literally just pack it in, right? And it's like that is going to stay there. That is not going to move, right? Especially when you combine that with techniques like ice cream cone technique there, where you're putting a membrane there to keep it in one zone. That thing is going to stay there. It just doesn't move, right? And if you're in a situation there where you're kind of thinking, okay, when we're talking about progression, it's kind of like, okay, when I first started doing membranes, I was terrible at them. I was absolutely, until I figured out a technique, which was like, okay, I used to do suturing over it, and that was my preferred, because I kind of found it's the best way I could secure it. I was never really that great at tacks, and now I use self tap screws, which I find very straightforward. But basically, you might find, I've put this autogenous graft around, I'm putting this membrane, oh my God, it's not fitting, it's stretching, the autogenous is falling out the side and stuff like that. You make sticky bone out of it, it'll stay there. You stretch your membrane over, it helps you a little bit there with the handling and stuff like that there as well. So it's a very nice technique to use. And actually on the course, you're going to be taking my blood to actually do a demonstration there. So yeah, it's gonna it's
Be hydrated, man. Don't come in with shitty veins.
I'm gonna keep some weights on the side. I'll do a pump before that. So yeah, I mean, a lot of these techniques there are basically the way that I look at it is there are certain things that that biomaterials have an advantage on, right? Not from their turnover, but in terms of their delivery, their ease of use, their handling, stuff like that there as well. And my thing was always like, okay, do you know what? If I'm going for autogenous, it's going to be so much more difficult. That it's going to be so much more traumatic for the patient and stuff like that. The whole point is having the education and the ability to do those techniques there on a patient, while at the same time they're trying to make it as similar to those advantages of the biomaterials as possible. I can design something that is very easy to handle with sticky bone. I can design something there that is that stays in one position, like Palachi's GTO, right? You know, you can make something there that kind of, kind of stays in there as much as possible. And you can design things that have ease of delivery there. You can design things that are easy to suture, etc. You just kind of have to know those techniques in order to do it. And the main, when you're looking at, I was I was watching a nature documentary like a week or so ago, right? And it's about I don't know why it's about Australian creatures, right? And obviously they have loads of spiders and stuff out there. And one of the things that they was talking about was this spider that makes extremely strong silk, right? And there's this thing that spider silk is much stronger than anything that we can make. It's stronger than steel, basically, right? The way that I look at biomaterials is the same thing. When Palachi is, who's an incredible surgeon, like Palachi is an amazing surgeon, right? He's like, this GTO that we've created is like sticky bone, right? Or when they say like, oh, this material turns over 50% into natural bone, right? Or this material there is basically comes from the same species as as the natural bone. Every single thing is trying to be compared to that gold standard, the same way that that steel is being compared to that spider silk. But the thing is, it can't be replicated. Then, like we're saying, there may be when we're, when we're, old guys, talking about talking about the olden days, we might be like, you know what? Yeah, this new material is amazing. You just sprinkle it in, and it's like the bone just grows and stuff. But right now, there's nothing like that. And kind of what I think to myself is, okay, if there was a massive problem with trying to harvest bone on a patient, and it was so problematic that literally, like, if you were trying to harvest bone on the patient, there was a risk that they're gonna say have a stroke while you're doing it, right? And that's a risk of any surgery, but say for example it's a very high risk of that, or there's a very high risk of cardiac arrest if you open a flap around the ramus, right? Then I'd say, okay, you know what, biomaterials probably a better option to go for, right?
No.
But the thing is that I think one of the reasons why biomaterials have become so high level is because the fact that when people are doing spinal surgery and things like that there as well, they've got to harvest huge amounts of bone to try and kind of reconstruct these sites. We're harvesting magnitudes less. We've got much smaller sites to reconstruct, right? And the one thing we've got to think about ourselves is, you got to believe in yourself. You can do this. You're putting an implant in bone. Why can't you push that bone open? What you can,
Yeah.
if you're doing that, if you're putting an implant in bone, then you have the skills to have a mini saw, cut a trapezoid cuts in there and push that bone open. You have the ability to do that kind of thing. If it's not that much of a massive step there on top of that. And this is the whole thing about the progression, is that there are progressive levels and you can stop at any kind of stage. But I believe there is a level, and I think you believe this there as well, that there is a level that I think that all people placing implants should get to, at least to know that they can do that procedure there if there is any kind of issue. A rid split technique or an expansion technique there, or a bone core technique, things like that. Those kind of things there, I think, should be a normal thing that just every implant surgeon there can do, as opposed to thinking, oh, there's a bit of a defect here, let me get something out of packet and put it on. Like we said, those things have their place. You need to use them in the correct manner, right? But if the option of autogenous is there, that's always the number one. Everything after that comes second. If the option of autogenous isn't there, right? And and you got cases there where basically like if you tried a slow drilling technique, you just get a blob of fat coming out from of the osteotomy, right? You wouldn't be getting any bone there whatsoever. Then fine, we've got options there for other kind of things, but it's um the one thing I've especially learned from our mentor is that basically like the more you learn, the more you realize you have to learn, and the less you actually realize you know about these techniques, and you kind of think, man, I wish I did this 10 years earlier, or I wish I got to this like at an earlier stage there. And yeah, I think people when they actually see the kind of things that are possible to do with autogenous techniques, I think a lot of people are going to be like, well, what, actually I could do this, I could do that. Yeah, it'll be kind of like an eye opener for a lot of people. And you're going to see a lot of that kind of that progressive style of learning techniques, on that course. I haven't just come here just to plug the course though. I just kind of just like just wanted to talk about a lot about it, because it's kind of like there's a lot of, both myself and you put in a lot of work into it to try and make it as memorable and as easy to understand for people as possible.
But I think I think another aspect of it as well is we need to be careful when when a new company or an existing company puts out a new product, and quite often what they'll say is, "Oh, compared to gold standard, it's as good or it's better." And you say to them, "What do you define as gold standard?" And they say, well, gold standard is BioWAS, because that's what's been around for the longest. And, BioWAS has been around for a very, very long time. Yes, it has its place as we've discussed. I know Prof. Urban, I know Balaji, they use BioWAS when they're doing vertical grafts, because they like the fact that it doesn't resorb, so it maintains that height. So again, we're not sat here saying biomaterials don't have any place whatsoever. They just need an appropriate usage. That's what it comes down to. But a lot of these companies turn around and say, well, it's as good as BioWAS. But we've already said that. BioWAS, sometimes you're going 20 years later, hasn't turned over into bone. If you're going to compare it to something, you need to compare it to the true gold standard, which is split bone block technique. That's what it needs. So it needs to be compared to Prof. Curry's technique. And these are the questions that, and I say this, and it's not, I'm not having a go at any company. I understand that all of these companies are in business, et cetera, et cetera. But what they're relying on, implant companies as well, is they are relying on your average dentist accepting what they get told, or just looking at an abstract and going, an abstract from an article and saying, yeah, that's good. Whereas, an abstract is nothing. You need to go into because sometimes an article can be really poor because it's manipulated an XYZ way, but you read the abstract and it sounds absolutely fantastic. So we need to look at the real data. And as you quite rightly said as well, others, sometimes it's, the more I learn, the more I think to myself, how the hell does any of this actually work? Because there's so many factors working against us. But simply, it's almost like the luckier I tend to get as well. It's actually quite a humbling process as well. But I think as a minimum, dentists should have in their armamentarium the ability to do ridge preservation with autogenous, and to do very simple grafting with autogenous. Okay, just as you would with any biomaterial, there's a cutoff point where the basics need to be covered, and if you don't want to do the rest because you're not comfortable with it, cool, send it out to somebody else, or have somebody else come into your practice. That's fine. But we need to have the basics done, and particularly in the maxilla, particularly when I'm using like a vascularized rotated CT flap as well. The flap that I need to raise there, I just harvest bone from the palate. I love bone from the palate. Okay, it's just phenomenal bone. It's autogenous. It's cortical. It's the regeneration that I get from that is just absolutely crazy. So you know what is if I've got a tooth where tooth's coming out, immediate implants going in, and I want to boost the soft tissue biotype by doing a rotated flap. It's like, hang on, the flap's already there. I just need another 30 seconds of autogenous bone harvesting, and I've got autogenous everywhere. So sometimes it's just thinking how we approach these cases, as opposed to just going through the motions. And as you said, the reasons why we're here is, we've kind of like had very similar career trajectories, and both of us about the same time we started to gravitate back towards autogenous, and we just wanted to share with everybody kind of like our journeys really. And as I said, it's I'm happy with the results that I'm getting. I'm doing bone core techniques. It's getting very, very, very nice results with it. Again, bone core technique. Listen, man, I know some people call it carrot or carota technique. I don't know why. It doesn't sit well with me.
It doesn't look like a carrot, though, does it? It doesn't look nothing like a carrot.
Bone core sounds cool. Yeah. And again, this is a technique devised by Prof. Khoury. So it's such a genius technique from such an amazing surgeon, and it just makes sense that you use these special Meisinger trifines. You take out the bone core where you're going to be placing the implant anyway, so actually there isn't a second site, and you just fixate it to the outside. It's just a beautiful, beautiful technique. But yeah, that's why Uz and I are here today, just to kind of like share with you our journey away from and back towards autogenous.
Yeah, I mean, this is the thing. Like, there's so many aspects of this. I mean, one of the things that I kind of like is saving a patient from having to have extensive treatment. Is one of the things that I just absolutely love doing. I see patients. I saw a patient the other day. She's basically got a bridge, upper left 4 to 6, and the forward split, basically, right? So around the, it's got that typical kind of appearance. You got bone around the 4. It dips around where the 5 is, right? So the sinus dips right down, and then it comes back up around the 6, right? So I just said to her, do you know what? We'll take these out. We'll take some bone, from the ramus. We'll put it in there, and if it goes to plan, then there's cortical plate all the way around this bone. It's completely sealed off. If we can resurrect this site, then it's going to save you having to have a sinus lift. Because if I can, I know the roots around the 4 and the root around the 6 there is 13 mils long, and even if I lose 10%, 15%, whatever, I've got autogenous bone around the whole thing. And we've basically just done this recently, and I've managed to place implants in both those sites there with autogenous grafting. And the plan is obviously we're going to place a bridge on there later on. No sinus lift, no nothing, because I know she's got from the scan. I know she's got like so much bone around there. Why am I bothering then subjecting her to a more difficult surgery, doing a sinus lift, bone graft? That's when when people are talking about second site morbidity, or you're going to give the patient more morbidity. Do you know what? The sinus lift is going to give them a lot, right? That's going to give them a lot of pain and discomfort. But if I lift the ramus and I take a bit of bone and I just put it in there, I've saved that lady a sinus lift, and I've saved her money as well. And they think you're some kind of hero because it's like, you know what? They've saved me from this dreaded sinus lift that I read on Google is the worst possible thing ever. That actually for me, that really makes me satisfied in doing treatment. I do so many of these now where I'm literally just like, I can see the bone around, let's graft it, go back in there, straightforward placement. It's just my protocol.
I'll tell you what it just reminded me of, and everybody's going to be able to relate to this. Yeah, anybody who places any number of implants is going to be related to this. Occasionally, maybe 2-3 times a year, you'll come across a patient where they'll turn around and say, I had a tooth taken out 2 years ago. The space is driving me mad. And it's normally an upper or lower 6. And they say that, they say, I'm here because I want to have an implant put in place. And your immediate thought is, oh God, it's taken out 2 years ago. There's going to be some bone loss, but you look, and clinically it looks really good. And then you've got this nervousness inside you that, okay, it looks good clinically, but how much of that is just a ridiculously thick soft tissue and the rest of, is going to be reconstruction? And you take your PA or your CBCT and you know what? There it is. That beautiful healed ridge that is going to take you 5 minutes to put an implant in, and you can do it flapless if you want. So what we're talking about is we are talking about trying to recreate that predictability with 100% autogenous bone. Because in those cases where the patients had their tooth taken out a couple of years ago, the ridge is all like fully healed with no bone loss or anything. What have you got there? Autogenous. And we know that, what do we say? We say the bone gods are smiling at me today. So we're trying to recreate that with a bit more predictability. Yeah, so that was when you were talking, that just kind of reminded me of that, really.
Yeah, it's just sometimes and this is mainly because of the fact, I think the main reason why I've gone around that route is because I'm a visiting surgeon and I just go around all these and then sometimes I'm just like, I don't want to do a difficult treatment. I don't want to do a treatment there that is somebody is going to have to check who may not have the skill, knowledge, or ability to look at and maintain. I want to make it simple, and I want to go in there, do the treatment, easy to maintain for the patient. There's no risk of dislodging any grafting material or anything there later on. It's just pure autogenous, straightforward case. 40 odd minutes to place an implant, and then that's it. And it's, for me, when I first started it was difficult to do, and it's difficult to get your mind around actually doing it. But then, after you do it there for a while, you're actually like, I can do this. This is straightforward. And then you do it more and more and more and more. And then suddenly it's like, okay, fine, I'm just going to do it easy, and that's the kind of route that I want, the delegates to be going down. That's the kind of, if I hope we can convey something across there to them, it's like, we can make this so this is as predictable as possible there for you.
Yeah, it's like, because I was first introduced to Automax burrs by Avik when he was mentoring me when I was working at his practice. And, Avik's a phenomenal surgeon, and he just goes, watch how easy it is to harvest autogenous bone. And he just went bang, bang, bang with the Automax burr, and he goes, look how much bone we've got. And I was like, is that it? And he goes, yep.
Yeah, it's like okay. Literally like it's like 10 seconds. So I did say earlier I was going to talk about this tonight, but I'll just briefly just say what it is. An Automax burr is a tree fine, a modified tree fine with a cutting tip, and it has a stopper on it. Right, so basically it's got a 4mm stopper. So if you check from CBCT there before, you can pretty much safely go into external ridge with no real problem. I'm not going to say every single time, because those cases there where you've got a very lateral nerve, you need to check from CBCT. But generally, it is literally just like, okay, go in there. Like, if you use it once, you got half a cc, right? That's pretty much most of my premolars and incisors. Half a cc, right? Then, because I'm bulking this out with PRF as well, right? So, I don't even need that much. The other times there is if you're doing bigger teeth there or more size, you go in there 2-3 times. But literally, you go, when I first started doing this, I was doing this at like 150 RPM, and I was like, oh, it's a bit, scary or whatever. And now it's just like 500 RPM, boom, go in there, do it, because it becomes second nature. It's that, I've heard you on the podcast talking about muscle memory a lot, building up that muscle memory, building up that kind of, that kind of thing where it just becomes second nature to do it. And, I think that's one of the things there that is lost quite a bit with our kind of generation of surgeons. Like, I told you this story before about my grandfather who used to sit on the, he was a plastic surgeon, used to sit on the dining table and he could suture with both hands. Like he would literally, he had a piece of leather, and he would literally be suturing like that, and then suturing like this, and it'd be like, I wouldn't really know what he was doing, but my dad would be like, yeah, he's like, he's practicing suturing and stuff, and it's like, this is a man who was in his 50s, who's been practicing in medicine for a very long time, doing surgery for a long time. He's still on the table doing this kind of thing. And for us, we kind of think, we don't need to do that. That's, why do we need to do that? That's easy stuff. But it's just that mentality of being like, I have to constantly train my brain into making this complete second nature. That's in effect what we want to be teaching the people there who are coming.
Yeah. Uz, thanks for joining me this evening, mate.
That's good. Yeah.
So always good to speak to you. So a few bits just before we wrap up. For anybody who wants to know more about the course, you can reach out to either myself or Uzman on Facebook. I'm on Instagram as well. The course is being run through JNS Davis, so you can go directly to them as well. And I'm also really happy to announce my website's been updated as well, academyofimplant.excellence.com, and I'm rather happy with it. It looks really good.
It's a good website. It's a good website.
It's really nice, yeah. So there's payment options for the Ultimate Implant Online course, where you just sign up straight away. You can split the payment over 6 months. And I'm really excited to be going to Cuba with a handful of the delegates later on in the year as well. So, yeah, it's really exciting and busy. So I'm happy with the way that the Academy is building. I'm putting a lot into it. Mate, it's turning out to be a monster.
Yeah.
I thought all 3 modules are going to be finished by now, or we're just coming to the end of the essentials.
I've said there before, I was like, mate, maybe could you just give me some access to this? I might just actually read through this whole thing, just refresh the knowledge and stuff like that. You know what I mean? It's extremely, extremely comprehensive. The one thing is, I would say, is that every time you learn something, you put that in. So every time our mentors are telling us certain things there, you're like conveying that. So it's constantly updating and refreshing itself.
Yeah. But I'm happy with it. Uz, thank you very much for joining me, mate. Folks, thank you very much for listening as well. And the next podcast, I've already had an idea what I'm going to discuss. I'm going to discuss the best implant system on the planet. So you're going to learn.
No.
You're going to hear my thoughts on what I think is the best implant system on the planet. And I may even record that tomorrow. We never know.
Wow.
So
okay.
Uz, thank you very much for joining.
No worries, dude.
Thank you, Tiny Nerds, for listening in, and please share the podcast with friends. I don't care, even if they're not dentists. If you got friends and family who are in a completely different profession, still get them to listen in. I don't care; it helps me out. If you give a like, thumbs up, whatever it is, it's always very much appreciated. And thank you for listening in, and I'll speak to you folks soon.